Hello and welcome to the Clinical Care Options Infectious Diseases podcast. I'm your host, Zachary Schwartz. Today's episode is on long-acting antiretroviral therapy. It features Dr. Daniel Kuritzkes from the Brigham and Women's Hospital and from Harvard Medical School. He'll cover the key trials on long-acting ART, he'll give practical insights on how to start, and he'll review factors that affect treatment success. This episode is taken from our larger series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. The show notes also have a link to the full program, including other podcasts, webcasts, and slides. So let's get started and listen in to Dr. Kuritzkes.
Well, let's go through the data. The Atlas and FLAIR studies were phase 3 trials of long-acting intramuscular cabotegravir plus rilpivirine after initial virologic suppression with oral therapy. In the Atlas study, adults on stable antiretroviral therapy, which could have been either a first or second regimen, with suppressed viremia for at least 6 months and no prior history of virologic failure, were randomized either to an oral lead-in phase with cabotegravir and rilpivirine or to continue on their baseline antiretroviral therapy. And then after 4 weeks, those randomized to the CAB rilpivirine arm switched to receiving monthly injectable long-acting cabotegravir and long-acting rilpivirine. They were followed for 48 weeks until the primary endpoint. In the FLAIR trial, treatment-naive patients with virus loads greater than 1,000 who did not have active hepatitis B virus infection, had no resistance mutations for NNRTIs other than the K103N, were initially placed on an oral regimen of dolutegravir or bacavir 3TC for 20 weeks, and those who achieved virologic suppression were then randomized again either to an oral lead-in with cabotegravir rilpivirine or to continue on the fixed-dose dolutegravir or bacavir 3TC combination. And at week 4, those on CAB rilpivirine switched over to receiving injectable monthly long-acting CAB and long-acting rilpivirine. The primary endpoint for both trials was occurrence of viremia above 50 copies per mil at week 48 by an FDA snapshot analysis. This slide shows the outcome of the Atlas study. And here, because the patients were already virologically suppressed, the trial is considered a switch study, and therefore the primary endpoint is virologic non-response. You can see that 1.56% of the people in the long-acting CAB rilpivirine arm and 1% in the continued baseline ART arm experienced virologic non-response, which met the non-inferiority endpoint. Looking at the more traditional endpoint of virologic success, we can see that 92.5% of the patients in the long-acting arm and 95.5% in the continued baseline ART arm maintained virologic success, and that too met the non-inferiority endpoint. The FLAIR study had a very similar design, similar endpoint, again, because people had been suppressed on dolutegravir or bacavir 3TC for 20 weeks before the randomization. This is considered also a kind of switch study, and therefore virologic non-response is the primary endpoint of interest. And nearly identical proportions of participants in both arms at 2.1 and 2.5% showed virologic non-response, again, easily meeting the non-inferiority margin. And if we look at the virologic success rate, the numbers are virtually identical. And once again, for the secondary endpoint, non-inferiority was observed. There were no additional confirmed virologic failures between week 48 and week 96 in the continued follow-up of this trial. But what about the emergence of drug resistance in these two trials? In the initial follow-up phase, the first 48-week follow-up for the two trials, there were 3 virologic failures associated with resistance in each study. Interestingly, 5 of the 6 individuals in whom virologic failure with resistance was found were from Russia, with the 6th person being from France. There were 2 of the individuals from the Atlas study had evidence of pre-existing NNRTI resistance mutations in their proviral DNA and identified retrospectively from a baseline sample. all of the participants who had virologic failure had emergence or presence of NNRTI resistance mutations, and 4 of the 6 had emergence of integrase strand transfer inhibitor associated resistance mutations. In this slide, 74I was listed as a resistance mutation, but in fact it is now known that this is a prevalent polymorphism in the subtype A viruses that circulate in Russia, and subsequent work has shown that that mutation or that polymorphism by itself does not confer any shift in susceptibility to cabotegravir. There were 100 or so participants who had the 74I substitution in the FLAIR study, 64 of them from Russia, 60 with the subtype A virus. And the presence of this polymorphism by itself did not affect the proportion achieving or sustaining virologic suppression at week 48. And at week 96, there were no additional cases of treatment-emergent resistance. Now, ATLAS-2M was a continuation of the ATLAS study for the subsequent 48 weeks and then continued beyond for additional follow-up. Here, participants who were already receiving injectable cabotegravir, rilpivirine, were randomized to either continue on the every 4-week dosing regimen or switch to every 8-week dosing. In addition, those who had been in the continued baseline or oral antiretroviral arm could, if they were interested in coming into ATLAS-2M, have the 4-week oral lead-in and then be randomized to either every 4-week or every 8-week long-acting injections, as well as people who had not yet participated in ATLAS, but who were on a suppressive regimen. And so altogether, there were a little more than 1,000 participants who were in ATLAS-2M. The primary endpoint here was maintenance of virologic success, a failure to maintain virologic suppression at week 48 of ATLAS-2M, with secondary endpoints being virologic success. And that is shown on this slide here. Looking at the outcome, again, this is a switch type study, so virologic non-response is the endpoint of interest, and you can see it was 1.7% for the every 8-week arm and 1% for the every 4-week arm, meeting the non-inferiority margin. And for continued virologic success, it was roughly 94.5% versus 93.5%, nearly identical numbers, and again, easily meeting the non-inferiority margin for this secondary endpoint. Let's look at virologic failures, injection site reactions, and patient preferences in ATLAS-2M. In the 8-week arm, there were 8 participants who had confirmed virologic failure, as compared to only 2 in the every 4-week arm. 6 of the 8 failures in the every 8-week arm had evidence of rilpivirine resistance-associated RAMs, as compared to 1 out of 2 in the every 4-week arm. You can see the particular resistance mutations listed on the slide. In addition, 5 of the 8 with virologic failure had resistance mutations to the integrase inhibitors in the every 8-week arm, as did both of the virologic failures in the every 4-week arm. And again, you can see the particular mutations that emerged listed on the slide. Injectable cabotegravir and rilpivirine was well tolerated. The vast majority of the injection site reactions were just grade 1 or grade 2, with a median duration of only 3 days. When surveyed during the study, patients preferred injectable cabotegravir and rilpivirine over oral therapy. And participants who had previously been receiving the injectable regimen every 4 weeks in the first phase of ATLAS preferred the every 8-week dosing over the every 4-week dosing. The FDA approved long-acting cabotegravir and rilpivirine in January 2021. The regimen was approved as a complete regimen for HIV infection treatment switch in adults who are virologically suppressed on a stable ART regimen, who have no history of treatment failure and no known or suspected resistance to either cabotegravir or rilpivirine. The approval also requires an oral lead-in with cabotegravir and rilpivirine for approximately 1 month in order to assess tolerability and to exclude the possible occurrence of hypersensitivity reactions. In addition, patients who are going to use long-acting cabotegravir and rilpivirine should initiate intramuscular gluteal injections of cabotegravir 600 milligrams and rilpivirine 900 milligrams on the last day of the oral lead-in period, and then continue injections every month thereafter. The Department of Health and Human Services Antiretroviral Guidelines panel has issued a statement on the use of long-acting cabotegravir and rilpivirine, which is summarized on this slide. The guidelines panel states that intramuscular cabotegravir and rilpivirine can be used as an optimization strategy for people with HIV currently on oral antiretroviral therapy who have documented suppression for at least 3 months, so long as they have no baseline resistance to either medication, no prior treatment history of virologic failure, don't have active hepatitis B virus infection, unless they're also receiving an oral agent active against hepatitis B that they will continue, are not pregnant or planning to become pregnant, and are not receiving medications with significant drug interactions with cabotegravir and rilpivirine that would interfere with either oral treatment or the injectable treatment. The question of whether an oral lead-in phase is essential is being explored in the direct-to-inject follow-on study as part of the FLAIR extension. Here, participants who were suppressed on dolutegravir or abacavir 3TC in the control arm of FLAIR could switch to injectable cabotegravir or rilpivirine beginning at week 100. And those who chose to switch to the injectable regimen were randomized to either do so with or without an oral cabotegravir rilpivirine lead-in. You can see that there was really no significant difference in virologic outcome between those who did or did not have the lead-in. Virologic non-responses were less than 1% in both groups, and virologic suppression was maintained at more than 90% in both groups, although there were more missing data from those in the lead-in group, which led to the difference in viral suppression rates by the snapshot analysis. In addition, an analysis has been done to try to understand what factors contribute to the risk of treatment failure in patients receiving long-acting cabotegravir and rilpivirine. And this was a post hoc analysis of the 48-week data from ATLAS and FLAIR, as well as the 48-week data from the ATLAS 2M study. This analysis used a backwards elimination model for covariates and identified a number of factors that were associated with an increased odds of confirmed virologic failure. These included the presence of rilpivirine resistance-associated mutations at baseline, the trough concentration of rilpivirine at week 8, presence of HIV subtype A6, which had previously been called A1 in those earlier slides from the original ATLAS and FLAIR 48-week analysis, and having a BMI of 30 kilograms per meter squared or greater. Every 8-week dosing was not a significant factor in the occurrence of confirmed virologic failure. In addition, failure was really most likely in participants who had at least 2 factors present, because no single factor was really highly predictive of the risk of virologic failure. Here are the key take-home points. Long-acting cabotegravir plus rilpivirine is a safe and effective regimen for persons with HIV infection who have documented viral suppression for at least 3 months and no history of treatment failure and no known or suspected resistance to either cabotegravir or rilpivirine. The FLAIR study found that the injectable regimen was not inferior to daily oral dolutegravir or abacavir and 3TC, and the ATLAS trial found that this injectable regimen is non-inferior to standard daily oral ART. ATLAS 2M also found that injections given every 8 weeks were non-inferior to injections given every 4 weeks. Contraindications to the use of long-acting cabotegravir or rilpivirine include active hepatitis B virus infection, unless the patient is also receiving an oral regimen with activity against hepatitis B virus, pregnancy or plans to become pregnant, or receiving medications with significant drug interactions that may affect cabotegravir or rilpivirine concentrations. In addition, at the present time, switching to long-acting injectable cabotegravir rilpivirine requires an oral lead-in phase of approximately 1 month in order to assess for the tolerability of these two agents.
Thank you very much, Dr. Kuritzkes, and thanks to you, the listener. To listen to more episodes in this series, and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you, and we'll see you soon on the next podcast.